Good morning, everyone, and a very, very warm welcome once again to yet another Empower Hour from Association of Nurse Executives India. Association of Nurse Executives India, ANEI, is committed to patient safety towards zero harm. The entire year of 2023 was committed to discussing patient safety events. The Patient Education Committee of the association have gathered 100 patient safety events or near misses. And we are very happy to announce that at this moment it is under works for releasing it as a book. And hopefully, once it's released, all of you will buy a copy and use those stories to share with current nurses, future nurses, so that they can understand what all problems can occur and why do they occur and what can be done. And in the book, we are also giving learnings for nurses and for educators and administrators, going to be a very useful tool for the academicians as well, because we cannot wait for everyone to do all kinds of mistake to learn from our own mistakes. So if we don't learn from others' mistakes, I think we are not being kind to our patients. To err is human, but not to learn from others' mistakes is criminal, especially in healthcare. We must invest in that. And that's what we have done this entire year. And this is the 11th month, November. We have Delhi chapter who is going to host this discussion today. But before I invite them, I'll share with you a few slides about information of ANEI. Just give me a second. So, friends, the book is going to be called as Life. Life means learning ignited from errors. And that is what we have invested, and it will come out as a book. And we have 11 incidents that we have discussed throughout 2023. And in December, we have planned for a mega quiz based on those events. So more details will be given slowly. And we are also very proud to say that before the International Patient Safety Day, every year in September, we have our annual Patient Safety Conference. It was a huge success. And we started our pre-conference workshop by training students on international patient safety goals. And we are continuing to do that. The target is to train 1 lakh nurses by next year. All chapter heads of ANEI, they all have been very actively participating in ensuring that we are training more and more students. This is our contribution to empower the future nurses to understand the most important domains of, patient safety. And we will continue to do that. There is Train the Trainer before this is being conducted by those trainers. If you are interested, the information is available here. And after doing the Train the Trainer, you will get all the contents, the presentations, the whatever is required to run the workshop. It's a 4 hours workshop that will be facilitated by the trainers who are trained by Association of Nurse Executives India, and they also get a certificate that they have undergone the faculty training program. So if you are interested, you can always write to annietreasurer@gmail.com, and this WhatsApp number is also here. I will wait for a moment. So in case you want to take a screenshot, please feel free to take a screenshot from here. And then you will know that how you can contribute in empowering the future nurses, because this is dedicated for student nurses. So join us and help us to spread the training across India. So today, I'm very honored to invite the Delhi chapter to conduct the Empower Hour. Before I will request Captain Sandhya to come on the screen, I'll take another few more minutes to explain a few more things from our website, because this is one opportunity we get to tell the audience what ANEI is doing and what all things you can get from ANEI's website. So that is Captain Sandhya Shankar Pandey, who is the president of Delhi Chapter, and Dr. Professor Ravinder Kalra, who is the vice president of Delhi Chapter. The panelists are all of them in front of you. Ms. Ashwini, Dr. Ashutosh Chauhan, Ms. Sunita Mandal, Ms. Priya. They will be introduced by Sandhya as soon as I invite her. But my special thanks to Dr. Ashutosh Chauhan for joining this discussion. In the ANECON, in the month of May, we also had promised that, we will start unsiloing nursing. That means nursing will go out of the nursing department, try to involve other disciplines into our activities and discussion. And this is one way. Before also we had doctors joining the discussion. So we look forward to a very learning discussion that is going to be centered around a particular event. So I'm not going to talk about that. So I would say thank you for being here. And next month, as I told you, wait for the announcement because we will plan a mega quiz. We'll let you know more details about that. And so once again, if you are not a member of ANEI, please visit our website and join us for empowering nurses and to build a better future for our profession in our country. So with that, I'm going to just go back and just give me a minute. I will just take up the website and I'll take few minutes to explain few things to all of you. Just a second. So this is our website, ladies and gentlemen. So if you go here, I'm not going to explain all about the, our website, but I want you to look at this knowledge center. Joining is done from here. If you click join us, it will take you to the process of joining. So this is the knowledge center, and you will find here that we have already released leadership competencies, couple of position papers, recent global nursing news. This is work under progress. Useful repository is also under, we are working on it. What all, useful references can be put in there. Publications by ANEI members and patient education. This is because we signed an MOU with Patients for Patient Safety Foundation. So I would like to click on this and show this is something new that we have added. So when you go to click on that, you will find that medication safety, and this is all created by Patients for Patient Safety. If you need tools to help to educate your patients, these are all things that you can easily download, and then you just have to click here. It will ask some details. This is only for us to know that who has downloaded, and if required, we can reach out to you and ask how did that document help you to do that. So once you fill in the detail, it's all free, so you can download all of them. It's not a problem. So now going back, if you want to look at any other things, so like leadership competencies, so we have the competencies worked upon, and we have given the PDF documents for staff nurses, team leader, nurse manager, head of nursing. So please feel free to download them. And in case you have any concerns about any of the document, if you think that it needs update or something more needs to be added, you can write back to us in the contact details which is given here at the bottom of the sheet. You will have that, so you can read annie.reach@gmail.com. So you can write to us, and then we will keep a tab and we'll see that what needs to be done. So with that, this is the information I wanted to share today. So with that, I will stop sharing. And now it gives me great privilege to invite Captain Sandhya Shankar on the screen to take over today's discussion. Sandhya, hi, welcome.
Thank you, ma'am. Thank you very much. And
thank you.
Very good morning, dear friends. Ma'am, you were saying something. Sorry.
I said, thank you for being here. And now it is over to you. Now I go off audio and off video. Thank you.
But you're certainly going to be around, isn't it?
Yes.
Thank you so much. And good morning once again, my dear friends. A warm welcome to the ANEI Empower Hour. And As you know, this is the second last of this glorious series. I also take immense pride in announcing that Annie has come strong and marks its present in rolling this, sustaining and successfully pinning this flagship event, the Nurses Empower Hour, across the country. It's become a national flagship event of Annie, which is conducted every month. And we Annians take lot of pride in sharing knowledge, preparing the nurses for tomorrow, and of course, enriching, fulfilling, and contributing to the domain, to the fraternity in this small way. The recording of this session will also be available at any social media portals. Those who miss out, please do share it, because today's session is actually an interesting one, which has got a very unique and a very beautiful panel. And here I take a lot of pride in inviting my panelists, my colleagues here to this panel, who will be sharing their views, their thoughts towards patient safety and patient care. The topic is all about patient assessment, where we miss out on basics. So the patient assessment, missing the basics. We have just, although there is plethora of information on this, but before we dwell into the details, I would like to invite my panelists, and then subsequently we'll go ahead setting the context. And with this, allow me to share my screen. So the rich panel today comprises of, to begin with, a very experienced and eminent clinician with us, Dr. Ashutosh Chauhan. And Dr. Ashutosh Chauhan, I'll request you to please come on to the video and Miss Ashwini and Ms. Sunita, as well as Ms. Priya. A brief introduction about the panelists today. You need to know your speakers. Dr. Ashutosh is a senior consultant and surgical oncology and co-director of the Anand Cancer Hospital, NCR, and professor and head of Department of Emergency Medicine, Siddhartha Medical College, Bangalore. He's been associated with renowned brands like Yashoda, Matnayati, as well as HCG, and of course had a whopping and career spanned over almost more than 1.5 decades in Indian Armed Forces. An eminent writer and academician, owes 30 contribution in 36 national journals, as well as 12 international journals. And I'm glad to share that I had witnessed him taking bashings for the students on behalf of the medical and nursing students while I was a budding cadet in Armed Forces Medical College, and had seen him actually, taking the blames, because he always said that unless until we handhold them during this phase, they are never going to emerge as confident professional, and that this still echoes. And I respect you a lot for that. Thank you, Dr. Ashutosh, for accepting the invitation and being with us. Joining him, we have Miss Ashwini Sarikonda, a very vibrant, active, and energetic nurse leader, also an Annie member. She heads Fortis Hospital Vasant Kunj for the nursing services, and also a postgraduate and a management postgraduate. Had done certification programs in multiple areas, and probably that's the reason when for the people who believe that learning is a never-ending exercise and they keep exploiting it, probably she has emerged as a very confident, versatile, and an agile nurse leader. So glad to have you, Ashwini, here. Thank you for taking time out at this peak hour at 11 a.m. in the morning. We have, further a mixed skill group. We have an eminent and very highly experienced nurse educator, a senior nurse from Sir Gangaram Hospital, who had a long career of 27 years. But as you see that Sunita is an evolved nurse from being a critical care nurse, a dialysis, as well as, moving into supervisory roles. And then finally into a phase of sharing her experience, both practical and theory, in building the nurses. Ma'am Thangam, I would request if you could admit the 20 people and waiting in the lobby. And and of course, last but not the least, the charm of this panel, the soul of this panel. We have a very young, a Gen Z, a young nurse, Priya Kumari, and she's a clinical nurse. She's working in the neurosciences specialty for last 3 years, a very bright, dominant, and as goes to this category of generation, I say, and I'm glad to share that she just proved very correctly that not scared, no inhibition, and not subservient, not indominant, but yes, very expressive, firmly taking all the opportunity to express and put across her point. I really love the way she actually expressed, cutting the points on putting her views that, yes, this is what I'm thinking. So, Priya, so glad to have you here. Hope you become an inspiration for the audiences whom you interact today. Priya has graduated from Saraswati College of Nursing, Punjab, and currently working at Medanta, the Medicity in the neuro department. So, as the panelists are already onboarded and are on video, I put across one interesting story to all of you. Have your eyes and ears glued to the screen this morning, and here it goes. In a hospital, 62-year-old lady underwent total knee replacement and the surgery was successful. On the fourth post-operative day, the patient complained of discomfort, loose motion, loss of appetite, refused to get herself ambulated while on rounds. The nursing supervisor, on being told about patient's complaint, asked the assigned nurse what her interventions were for the patient. The assigned nurse answered that she had informed the resident doctor and he had prescribed the antidiarrheal drugs. However, the senior nurse was not convinced, and with the intervention that the resident doctor has prescribed the antidiarrheals and the assigned nurse has administered them sincerely, and the diarrhea has been addressed and been taken care of. So, while not being convinced with this intervention, she thought of further probing and knowing more about the patient. So she went back and asked patient a few questions. When did the patient had her last bowel movements? And being a typical 62-year-old Indian female from a suburban land, the patient who was hesitant actually melted down with a healing touch and just promptly replied that it's been 2 days I've moved my bowel. She was comfortable, and then when the in charge asked that was she comfortable after her bowel movements, the patient said that she feels that she is not emptied and evacuated completely. That's the reason she's not comfortable. Rather, the discomfort is now becoming extreme, and along with that, in a very hesitating manner, she said that she's continuously passing small amount of watery stools, which actually she was presuming that it is again diarrhea which is continuing. So senior nurse examined the patient, did some assessment, and then identified that patient had impacted stool. And the loose stool was just the liquid part of the impacted stool which was seeping from the body. The patient was counseled and assured, and she immediately informed the treating doctor. The doctor did respond to the in charge's call because he took it seriously, understood the urgency, and immediately reported to the ward, reported to the HDU. And then on seeing the patient, he removed the impacted stool, following that prescribed proctoclysis enema. But subsequently, the patient was relieved of the misery, started ambulating and eating as well as drinking well. Patient was prescribed the required medicine as well as advised to drink plenty of fluids and high fiber diet. But this all things till the interventions came in prolonged the patient's stay in the HDU, the high dependency unit, for 2 more days before the patient was stepped down to the ward. Right. So this was the story. Probably, I know I do relate that to each one of you. More than 100 of you sitting here must have encountered something of this sort in your nursing practice once at least till date. And while I say this, let's see and invite our panel that what's there more to learn, more to absorb, with some concrete take-home messages which we replicate and take it forward in our clinical practices. With this, my first question goes to Dr. Ashutosh. Sir, what do you think? What went wrong in this entire situation?
Sandhya, upfront, I can say that there was a lack of communication and physical examination on part of both the bedside nurse and the RMO. In fact, the RMO was a bigger culprit in this case. Put it like this, that the sister took the patient's word that the patient is passing a loose stool. What she missed out on was probably asking the patient when has she passed the stools last, and whether the patient is feeling comfortable, whether the patient is feeling constipated. She probably did not examine what was passed. If she would have examined it, she would have understood that this is not actually fecal matter. Now, apart from the bedside nurse, I would also say even the RMO was a bigger culprit, because he simply took the nurse's word and immediately prescribed antidiarrheals without actually having examined the patient. He could have palpated the abdomen, he would have immediately found that the patient would have been uncomfortable. He could have auscultated the abdomen. More importantly, probably the RMO did not apply his clinical sense that elderly patient, bedridden patient is more likely to suffer from constipation rather than diarrhea. So what I feel is lack of communication, lack of physical examination, which I will, if I bring it together, I would say both of them displayed lack of 3 A's. The 3 A's are lack of awareness, lack of alertness, and lack of attentiveness. That was the problem here.
Wow. Thank you. I think this acronym is going to be one of the mantras, and we'll come back on this little later. But you rightly said, viewing that situation did not went the desired way, but was there anything which really went well also? Let's look at the good and the nicer part. And I asked this from our experienced nurse administrator, Ashwini. Can you pick up any points that what went right here in this situation?
Thank you, ma'am. Good morning, one and all. And yes, I am here today with you all to share what I feel the right in this. Before that, each situation has two sides, right and the wrong. Both are equally important. Right things will make happy and the satisfied patient, and the wrong things will make us to think towards the learning for the next improve the gaps. Yes, I would like to appreciate here the in charge nurse critical thinking, and she did listen to her staff escalations carefully, and she had her suspicious, and that's why she went examine the patient and assessment as well as. And being as a female patient must have hesitant to tell about the leaking watery stool in spite of 2 days constipation. And when the nursing in charge have probed and assessed the patient, then she came to know that the patient had impacted stool. I truly appreciated the sensitivity, thoughtfulness, clarity of the in charge towards the patient problem. And the next one is the senior doctor who again believe in the in charge nurse. It shows that actually treated her reliable source of information and depend on her to make a clinical decision. Again, they examine the patient and confirm the problem and went further. So I really liked it, the way in charge and the senior doctor moved together, intervened and solving the problems towards the patient. And yes, I'm happy finally the patient was relieved of her complaint. Otherwise, patient would have gone with the bad impression about the hospital and the care as well. Finally, it's a great teamwork with the nurse have observed what she observed and escalated the way how the doctor intervened all matters to relieve the patient discomfort. These are the 3 points I could picked up as went right way. Thank you.
Thank you, Ashwini. I'll request if you can come on the video, please. Thank you.
Ma'am, it has stopped from admin
All
side.
right. You can, all right, fine. You can take the technical help from TG, and the needful will be done. So moving ahead and moving forward, while we know that Ashwini has actually very nicely put across that everything is well if ends well. But while knowing the both sides of this activity, this event, let's listen to our Birbal, our Tenali Rama, the so-called intellectual banks or in the hospitals, our educators. And I invite Sunita. Sunita, uh, can you share that why such misses happen at the bedside? Why such problems keep occurring? Because there's nothing new, rather the magnitude is increasing. As more and more awareness is setting in, the magnitude, the impact is increasing. So could you share your views on this, why such problems occur?
Good morning, ma'am. Sunita this side. Good morning to one and all. As ma'am was already introduced as I have a lot of things to speak and move forward with that. Thank you, ma'am, for that introduction. As ma'am already introduced me, an educator, whenever these type of incidents occur, already Ashwini ma'am has said good and bad, and I'm opted for the bad option, which was missed. So as an educator, I need to get into the detail of the situation, why it has occurred, so that I understand the situation and I can train my nurses so that these type of incidents does not reoccur again. Now coming to the misses, which I am supposed to point out, let me start from the basics. So when I talk about the basics, that means when a nurse comes for a shift, the first thing she has to take the handover from the prior shift nurses. So what I can see here is if she has taken the handover, which is being practiced in all the private sector as ISBAR, if this has been taken properly, these type of incidents would not have occurred. So as an educator, I would check whether the process is in place. And if it is in place, whether the nurses are practicing it correctly, whether they are doing it appropriately. First miss. So in this situation, I think the first miss was ISBAR was not done properly. Second, moving forward, checking on the patient's need and well-being. So when I talk about patient's need and well-being, here plays an important role of effective communication. If as a nurse, I'm concerned about my patient and I communicate with my patient, as ma'am already started with the session saying that when we give a caring touch to the patient definitely speaks up for herself or himself. Here in this situation, the nurse was not concerned enough to talk about the patient, or rather to maintain a relationship, a professional relationship, IPR with the patient. So if she had communicated with the patient properly, the patient would have definitely told us about the difficulty in elimination or
Just a minute.
moving on to third point.
Will request everybody to kindly mute yourself.
Nursing assessment.
Sulata Biswas, can you please mute yourself?
When we are talking about assessment, here we are supposed to do the assessment in every shift, which is not only limited for this post-op patient who had a surgery. Here, what I mean to say is whenever a nurse comes for a shift, she goes to the bedside, we can just have a head-to-toe assessment of the patient so that she can assess.
We lost connect.
Somehow we lost the connect with the Sunita. By the time Sunita, I think she conveyed her message and her thoughts very well, that yes, because of the lack of awareness, because of the
Went back.
workload, and yes, Sunita, we lost you in between while you were completing. You're back. Happy to have you back. You can unmute yourself and continue and complete your part.
Yeah, sorry for the inconvenience.
That's okay.
As was moving forward, we already jotted out 3 misses. First was when during the ISBA, that was the first point. Second, we discussed about the well-being of the patient, that was the effective communication, which you might have missed. And the third was assessment. So we won't be blaming the nurse for the situation. There has to be something which went wrong for which the nurse has turned up to the situation. So as an educator, I would go forward and find out what the reason was, why the nurse behaved that way. So it could be anything, because no nurses plan from home that she will commit a mistake or she will do a patient harm. So why the situation occurred? For that scenario, I have to dig into the matter and find out what was the main concern. Was she a novice nurse? Was she overloaded with burden with work? That is the nurse-patient ratio, or the allocation of the patient was not based on the acuity level of that nurse and the patient comparatively, or actually she might be struggling helping someone else, or she was busy assisting emergency situation. Any of these reasons could be there for this situation to come up. The third most important thing which I want to add on to this is the mentoring of the staff. So it is basically a culture mentoring of the staff, where we see the juniors always follow what the seniors are doing. So I have, as an educator, I have to see whether the process of mentoring is being practiced in that organization or not, whether the process of handbar is followed by the seniors or not, because juniors have an understanding to imitate the seniors. Now, if the seniors are not following the same, they are again coming into the same line and not practicing. So, ma'am, I would like to draw your attention that the culture thing has to be again promoted in the organization, and not blaming the nurse. This is something related to the process which has to be improved.
Sunita, I was not wrong in saying, and it actually felt like Buddha speaking. So thank you very much. Yes, you're absolutely right. Be the culture, but mentoring, time, awareness, hand-holding, and these are the things which impact. And I'm so glad, rather respect to the thought that when you said that it is we who have to take the responsibility rather than blaming. And the punchline was, no nurse decides from home in the morning while coming on duty that she's going to make a mistake. Yes, you're absolutely right. Sometimes it's inevitable. While I have said this, let me invite Priya, and let's have a view on her thoughts on Priya. Yes, thank you for being there. Priya, you are a clinical nurse. Whatever Dr. Saab, our nursing head, our educator, the seniors have said, you are the one who is actually carrier. आप वो हो जो काम करते हैं और patients की देखभाल करते हैं. You are the real custodian of patient safety and patient care, isn't it? So हमारे लिए ये जानना आपसे जरूरी है कि nurses से ऐसा क्यों हो जाता है? क्या सच में वो जानबूझ के करते हैं या अपने आप होता है? But why such things happen on floors? Because this is a very frequent and a recurrent phenomenon, isn't it?
Yes, ma'am. Good morning, everyone. First thing, ma'am, incomplete handover. जब हम हैंडओवर लेते हैं तो हम मेन चीजों पे फोकस करते हैं. फर्स्ट वन, मेडिकेशन. कौन सी मेडिकेशन पेशेंट को चल रही है, कौन सी एंटीबायोटिक स्टार्ट है, कौन सी एंटीबायोटिक स्टॉप है, कौन सा प्रोसीजर पेंडिंग है, कौन सा प्रोसीजर पेशेंट का होना है, पेशेंट एनपीओ है, कौन से ब्लड टेस्ट डॉक्टर ने प्रिस्क्राइब किए हैं. ये सारी चीजों पे हम फोकस करते हैं और जो बेसिक चीजें होती है वो हम मिस आउट कर जाते हैं ड्यू टू सम रीजन. फॉर एग्जांपल, नर्स के ऊपर ओवरबर्डन है पेशेंट रेशो का, ओवर डॉक्यूमेंटेशन, क्योंकि उसको प्रैक्टिकल वर्क भी करना है और थ्योरेटिकल वर्क भी करना है. अगर उसके पास 7 पेशेंट है, 8 पेशेंट है, तो वो प्रॉपर कम्युनिकेट नहीं कर पाएगी पेशेंट के साथ, और ना ही वो उसकी प्रॉब्लम जो है सॉल्व कर पाएगी, क्योंकि उसको एक पेशेंट बेड साइड जाना है तो उसकी टाइम मैनेजमेंट जो है वो प्रॉपर नहीं होगी. तो चीजें जो है डिले होती रहती हैं. बेसिक जो चीजें वो मिस आउट हो जाती हैं. जैसे हमारी शिफ्ट में इनटेक कितना है पेशेंट का, आउटकम क्या है, पेशेंट स्लीप पैटर्न कैसा है उसका, ये सारी चीजें जो है मिस आउट हो जाती है ड्यू टू ओवरबर्डन ऑफ डॉक्यूमेंटेशन. क्योंकि प्रैक्टिकल वर्क और थ्योरेटिकल वर्क जो है उसको दोनों करना होता है 7-8 पेशेंट का, और उसके ऊपर स्ट्रेस भी होता है कि सीनियर मुझ पे शाउट ना कर दे, डॉक्टर में पे शाउट ना कर दे. तो इन सब चीजों की वजह से जो है बेसिक चीजें मिस आउट हो रही हैं, और जो ये चीजें मिस आउट हो रही हैं बाद में जो ये मेजर जो है कारण बन जाती हैं आगे कन्वर्ट होने का. जैसे हमारे पेशेंट को जो है नी रिप्लेसमेंट हुआ था, तो वो 4th डे पे हमें कंप्लेंट कर रहा है कि उसको डिस्कम्फर्ट हो रहा है, डायरिया हो रहा है. अगर हमने उसकी फिजिकल एग्जामिनेशन अच्छे से की होती तो फर्स्ट सेकंड डे पे ही हमें पता चल जाता उसकी बाउल मूवमेंट कैसे है, तो वो चीजें वही सॉल्व हो जाती रादर देन कि वो आगे बढ़ती. तो ये सारी चीजें हैं, ओवर डॉक्यूमेंटेशन की वजह से चीजें जो है, बेसिक चीजें जो हैं लैक हो रही हैं। ये पेशेंट रेशो की वजह से हो रही हैं, सीनियर का स्ट्रेस है उसकी वजह से ये सारी चीजें लैक हो रही हैं, बेसिक बेसिक चीजें लैक हो रही हैं।
बिल्कुल सही. And just to sum up what Priya said, and Priya, salute to your courage and your expression. I wish all nurses in India become, like you. It's going to be a completely different journey when we witness this. Priya mentioned there is the nurses, staff nurses at the bedside are overburdened. They are overwhelmed. They need guidance. She said there is a lot of documentation, but we as staff nurses, we lack in doing a good patient assessment. There needs to be some transparency. And she also was candid in expressing that there is a lot of stress with the staff nurses from their own seniors, from the doctors and the others, on whether they shout or whether they are going to understand their situation or they are going to just explode. Thank you, Priya, for bringing this up. I'm going to come back to you in a minute, right, in the next round. But before this, I want to ask Dr. Ashutosh. And Dr. Saab, my question has three parts. First, has such situations made you explode at the patient side anytime? And second, how does this impact your clinical decisions? And if so, and moreover, how do you handle yourself in similar situations? Because there's nothing new which I'm talking. New is I'm asking you, how do you conduct and handle yourself, and what would be your message on this point? You're muted, Dr. Ashutosh, you're muted.
Yeah. Okay, Sandhya, that's a very good question, because listening to the nurse educator and listening to Priya, I could actually recall my journey of last 25 years when I was an intern. You remember me that time. And now as I'm running my own hospital setup. So I'll take your questions in three parts. Number one is how common are these errors, which is I'm reading from the question which you asked the other panelists. Number two is whether these things affect my clinical outcomes. And number three, which you asked, was how do I deal with it? So start with this. How common is it? I feel it is very common, quite common. Now, what initially as a junior surgeon and now owning a hospital, what I find is the most of the errors occur when there is the exchange of clinical charts in the morning. When the duty shift is taking place, the sisters are handing over their clinical chart. They are happening TPR, BP, pulse, urine output, and other things are being handed over. That's all right. But there are some critical inputs which are missed out. Suppose the patient has said the stool, the patient has passed stools. I would like input like what is the stool consistency, color, any blood, urine. Urine output is given in the chart. What I want to input would be what is the color? Is this cloudy? Is it bloody? Any other problem with this? One of the very critical important things is how's the patient feeling? Is the patient cheerful? Is the patient miserable? Is the patient in pain? See, please understand. I, as a consultant, am I going to see the patient for 5 minutes, 10 minutes, maximum 15 minutes in an ICU? But it is the duty nurse who has been with the patient for last 8 hours, who has got the best assessment of this patient. So whatever input she is going to give me is going to affect my clinical outcomes. One of the things which I found is that I do understand that the sister cannot be on the bedside of the patient all entire duration. So there is something known as a patient family basic education, which she is supposed to impart to the relatives. So as to pick up all those things. So that those may be missed. Now those are the critical inputs may be missed. Now I'll just expand something in which the Priya was talking about. I will expand it. In my experience, what is all this due to? I have found that lack of 3 A's, which I said. Number one is lack of awareness, lack of alertness, and lack of attentiveness. Since I have been running my setup for last 3 years, I have been paying very close attention to this and trying to get into why these things happening. So let's talk about lack of awareness. Lack of awareness may be because the sister herself is quite junior. She's just out of the college. She has had limited experience during the college. So that's all right. That is all inexperience. Or else lack of awareness may also come in the fact that the sister had been working as an NICU sister for last 4 years. And now she has been sent into a role in a post-op ward. She's just not aware. These are some things which I can't hold against her. This is something which has to come. Let's talk about lack of alertness. Lack of alertness, primarily the most common reason I found is the long duty hours and lack of sleep. That is what, especially in the night duties and the changeover in the morning, and even in the long duties in the morning. This is one of the common reasons which I found. And let's talk about something which is not recognized. Lack of attentiveness. Please understand, all these people who are working 8 hours a day, 7 days in a week are human people. They have got own personal issues running in back of their mind. They have got all the same issues. I, as a consultant, have got all the time in the world after seeing the patient go into the OPD and solve my personal problems. The sister doesn't have this problem. This thing keeps on running behind the mind. These are what we as administrators are supposed to look into, that there is something behind. Then there may be extraneous issues in something like administration, that they have got some problems with the administration happening, which is running in the back of mind. And another thing is, as Priya rightly said, the lot of burden about the paperwork. Paperwork in some of the hospitals insist that they should have electronic medical records, but they should also duplicate it on the in form of paper. That is actually increasing her burden twice. So these are the things which I, as a hospital, as a consultant, and now as a hospital administrator, have realized. So I thought I will put it across. So okay, now apart from this, let's go to the part 2 of your question. Does this affect my clinical outcome? Definitely. As I said, I depend upon the sister for her input. She is the critical member in my team. In fact, the patient care is most affected by the bedside sisters. She's the most important person. So all those inputs, like for example, in the urine output, if she has just given me, sir, the patient is fine, the urine output is at 1000 ml, and she leaves it at that, give me one set of mind. If she says, sir, the patient was feeling uncomfortable, the urine was slightly blood tinged, immediately my radar goes up. So look at it. My view, my whole idea of how I'm going to assess the patient is going to be affected by the input what the sister has given me. If the sister says, sir, this patient is comfortable, I will just move ahead. I will not talk to the patient also. If the patient says, sir, the patient has been restless throughout the night, I will stop. I will examine the patient. So please understand, it is the sister who's the critical link in my decision making. So yes, her outputs are extremely, extremely important for my clinical outputs. My patient walking out of the hospital or not totally depends upon the sister's group. That is the amount of respect I hold for the sisters. Okay, now that comes to the how will I react? Once upon a time, I was also a hot-headed idiot, but over the period of time, I've reacted. Now, similar situation as has happened in this particular case, the case scenario, which was how will I react? Number one would be, I will do no. What I tell my juniors also: do not lose temper in front of the patient. Do not admonish or scold or say anything to the sister in front of the patient. As far as for immediately reassure that the patient is everything is fine, and then take the sister aside and then talk to her about what was the deficiency. Now, what is the reason? These are very important reasons which even my colleague should understand is, number one, if I'm doing all this thing, the patient loses faith in the hospital, in the system. Number two, the patient loses respect for the sister. It lowers the sister's dignity in front of the patient's relative and the patient himself. And later on, these patient and relatives will not listen to the sister. So again, it will affect my outcomes. And number three, most importantly, in fact, that should have been number one point, is the sister herself gets demoralized and will be very afraid to open up next time when anything such comes up. As I said, I will take the sister aside and I will have a discussion in a more calm manner and try it, and it would be more of an inquiry, because I do feel, as was pointed out by the panelists, that no sister wants to commit a mistake genuinely. There are so many other factors which I told you can affect it. So it will be, the important thing is more in terms of an inquiry, how to better ourselves rather than in form of a blame fixing. I would rather talk to the junior sister myself, explain to her. In case I don't have time, then I will rather involve the nurse educator and let her handle the issue. That is how I will approach.
Dr. Chauhan, actually, I was speechless. I was totally immersed in what you were saying and thinking at the same time. If the nurses and the administrators are listening here, probably everybody would want to have you in their hospitals or would like to join you to be working with such clinicians. Thank you so much for being so empathetic in your expression. But I do believe every word you said, because there was a time when I had actually seen you practicing, what you said. From Dr. Ashutosh, I'm moving to Ashwini. Ashwini, so we are actually talking to the administrators now, and Ashwini, you do get numerous calls, yeah? Multiple times we have also connected on this issue, and doctors agitated, upset, and angry, calling you from ICU, from the ward, or from the hospital foyer, that nothing happens here, nothing moves here, nursing needs to be addressed and taken care of. So, but which are the common ones which actually literally derail you from your routine? But more importantly, how as a nurse administrator you handle this? Is there any tip you would like to share which has been successful for you in the last year?
Yes, ma'am. Thanks. I would like to share definitely the common gaps first. The missing gaps are the case specifically like the post-operative cases in the post-operative areas. Would like to mention the common one is incomplete instructions by the doctors. It might be illegible handwriting, it might be the verbal order, might be, and as well as the nurse awareness, those who carry out the instructions naturally. These points will be installed commonly in the post-operative area. The second one is inadequate handovers. However, multiple speakers have been mentioned about this. And something usually people do not give the importance to formal or the professional handover, which impacts the entire chain of the decision and the care for the patients. And the next one is workings like Xylos, be it doctors, nurses, physiotherapists, and the dietitians. Usually, everybody will do their work and goes, but not interfacing the each other. Insist that this is the point I am going to be insist the nurses, the point of contact and the concern care for patients. Now is a high time for the nurses to stand up and step up for owning the patients and nobody else. The nurses only can spend a lot of time with the patients and nobody else can understand like the nurse. And the next one, I would like to say one more. This is not only about this case and this intervention and the supervision, those who are experienced and more capable to be available all the time for the junior nurses to shadow them and handhold them, have to learn and have to motivated and have to be mentored under the senior nurses. And this is what I probably feels that senior lot of nurses, senior lot people has that responsibility on their shoulder to groom well and the handhold the junior nurses. And when it comes to the being as a nursing admin, really I'm smiling myself when you have asked this question, because this is happens very frequently the second alternate day in my professional area. Of course, I don't deny the doctors do upset, but there is a reason behind, and it actually empathize them. But my way of dealing with the doctors at these situations, usually I get calls and the roaring voice from the doctors. Then I will be usually attend with a composed manner. I will give enough ample of time to listen from them, and I will give the answer that yes sir, I will be there in the next while of minutes. Then if I am occupied, definitely I will send my the second in line, the decon, deputy chief of nursing. Usually I 99% I myself will be attend and listen from the doctors. Yes, I'll go there. I will give my piece of time to listen and patiently. I will take a minute of while and I will say that, yes, you're right. But give a couple of seconds to go back and come with the facts. And definitely, I will be here. Before you leave that, I will come up with the solutions. Then immediately, I will arrange a small huddle with the team people who are the directly or indirectly involved to create the gap for the patient. The nurses, I will allow them to speak up. nurses, GDA, in charge nurse, supervisor, whoever been part in that. And while talking and interacting only, we will come to know the process gap and the facts. This has been winning pointed, and over the period of time, the similar types of errors has started reduced, and like missing drug administrations, attending the call bills of the patients, and the input output chart at the critical care areas, and the many things. And so this hurdle definitely have reduced a lot of complaints, and might be this hoping that it will be useful for other people. Listening response in a composed manner, understanding and updating the changes, and following keep up the changes to be prevent for such further incidents. These are the my being as an administrator I would want to tell. Thank you, ma'am.
Very nice. Very well said. I think very practical. And most important, I really loved your tip on immediate huddle or the quick huddle, right? And probably this is something which correlates very well with Dr. Ashutosh also shared on not to actually pinpoint and accuse in front of the patients and relatives. And more importantly, taking everybody to a side for a quick huddle on what went wrong. These are the two things which plug the situation right in a most professional way, sustaining the confidence of the caregivers as well as trust of the patients. So hats off to both of you. But moving from Ashwini, from the administrators rather, to again to our educator Sunita. Sunita, we actually heard the generation gaps, we heard the concerns, we heard the tips to build a practical tips on mitigating the situation immediately and then subsequently how to make it better. But all these things, be it the seniors, the hospital, healthcare professionals, healthcare workers, patients, family, the work, the documentation, the patient care, the entire itinerary, I would say, laundry list has a cumulative effect on that one person, our nurses, the bedside nurses, the clinical nurses, right? So, and you have a very important responsibility of building them. The educators have a very important responsibility of building them to take charge. So, as a very senior and seasoned educator, what would be your, what's your plan? What do you do? And if you could tell us in brief, that will be really helpful for everybody.
Thanks for the question, ma'am. Thanks for the question. As an educator, my role includes everything, be it introducing the patient, be it shift handover, be it patient assessment, be it documenting and escalation. I have to see whether all these things are in the process, are there in the place or not. For example, if I point out my first point as the process, so I have to see all whatever we are talking. For example, if you're talking about process handover, whether that is there in the system, that is there in the process. Second, if it is in the process, is my nurse aware that there is a process called handover? Is by handover? And third, if it is in the process and my nurse is aware whether she is complying to it, whether she is doing it appropriately. So all these things has to be taken care by the educator, training them, teaching them, motivating and guiding them to apply the same in the patient care end. Now, if my nurse is not going through this, so I have to find out what is the challenge they are facing. And I have to get into it. I have to put my effort to make them understand the effort of all this process. And now once the process is in place and why it is not being complied. So I, being the monitor, I have to see the process has to be, if I have been put in that position as a monitor, I have to see that the process is being continued and taken forward. And if I see my nurses are not complying, I have to be the first whistleblower to again escalate the call to the administration so that the nurses can comply and work with ease. And that I have to do. So that sums up the responsibility as a nurse educator. Instead of blaming a nurse for not doing a thing, I have to try to improve the process so that things can be put in the manner we want.
Very nice. Thank you. And I really loved 2-3 words which you said, you being the monitor, you being the whistleblower, and the way you have actually addressed and spoken about the process, because process is something which probably the nurses have to champion and we need to take charge, right? So thank you very much for bringing this up, Sunita. Very valid. Thank you so much. And while we are heading towards the end of the session here, the last section, and I would say before we part, there is something important, and I invite our the little champion, our Priya. Priya, what will be your message if you want to give to all the nurses, administrators, the healthcare leaders through this platform as a from your point of view? बेटा आप क्या बताना चाहोगे कि आप लोग क्या चाहते हो, हम आपके लिए क्या कर सकते हैं आने करंट सिस्टम में जहां बहुत सारी चीजें हो रही हैं, कमी क्या है जिसके कारण पेशेंट सेफ्टी कॉम्प्रोमाइज हो जाती है, या फिर हमारी नर्सेस, हमारी स्टाफ नर्सेस जो हैं उनके कॉन्फिडेंस कॉम्प्रोमाइज हो जाता है, और जिसको जो हम आज की तारीख में और बेहतर वे में डील कर सकते हैं, हैंडल कर सकते हैं, एक बहुत कॉन्फिडेंट नर्स प्रोफेशनल को सपोर्ट कर सकते हैं. सो प्रिया, योर थॉट्स बेटा.
यस मैम, जैसे मैंने कहा था कि इनकम्प्लीट हैंडओवर होता है, तो उसके लिए हम जो एक नर्सिंग हैंडओवर चेकलिस्ट जो है मेंटेन कर सकते हैं, बट अगर उसको हम ऑनेस्टी से फील करें, उसमें हम मेन पॉइंट जो है ऐड कर सकते हैं, जैसे मेडिकेशन हो गया, प्रोसीजर है, पेशेंट एनपीओ कब से है, इनटेक कितना है ईच शिफ्ट का, आउटकम कितना है, स्लीपिंग पैटर्न कैसा है, ये सारी चीजें हम मेंटेन करें पेशेंट बेड साइड जाके, और ऑनेस्टी से उसको फिल करें, तो जो हमारी बेसिक चीजें जो है मिस आउट हो रही हैं उसमें हमें इम्प्रूवमेंट होगी. तो ये मेरा पॉइंट ऑफ व्यू है कि नर्सिंग हैंडओवर चेकलिस्ट जो है मेंटेन करके हम ये चीजें जो है इम्प्रूव कर सकते हैं. सेकंड, डॉक्यूमेंटेशन में मैम जैसे हमें प्रैक्टिकल वर्क भी करना है, थ्योरेटिकल वर्क भी करना है, तो हमारे पास पेशेंट रेशो ज्यादा होता है, तो सिस्टर्स जो क्या करती है, एक पेशेंट बेड साइड जाएंगी, दूसरी पेशेंट बेड साइड जाएंगी, उनको टाइम मैनेजमेंट का पता नहीं चलता है, और वो क्या करती हैं कि उनको ये स्ट्रेस है कि हमें प्रैक्टिकल वर्क भी करना है और डॉक्यूमेंटेशन भी करनी है. तो हमारे पास 6 आवर है, तो 6 आवर में उनको ये स्ट्रेस है कि वो 6 आवर में प्रैक्टिकल वर्क पूरा करें या डॉक्यूमेंटेशन कैसे फिल करें. तो मेरा ओपिनियन है कि हमारे डॉक्यूमेंटेशन जो है वो सिंपल और ईज़ी हो और लेस टाइम कंज्यूमेबल हो. थर्ड, कि सर ने कहा कि लैक ऑफ कम्युनिकेशन. यस, कम्युनिकेशन हमें अपनी इम्प्रूवमेंट करनी चाहिए कम्युनिकेशन में. हम जब भी पेशेंट बेड साइड जाते हैं तो उनसे इंटरेक्ट करें, उनसे कम्युनिकेट करें अच्छे से, ताकि उनका ट्रस्ट हम बिल्ड कर सकें. अगर हम उनके साथ अच्छे से कम्युनिकेट करेंगे तो उनका ट्रस्ट हम पे होगा, तो हमें अपनी चीजें ब्रीफली जो है एक्सप्लेन कर सकेंगे, जो भी उनको प्रॉब्लम है. अगर हमें ब्रीफली वो चीजें पता चल रही है कि पेशेंट को ये प्रॉब्लम है, तो हम डॉक्टर को भी अच्छे से उसको एक्सप्लेन कर सकते हैं, ताकि डॉक्टर जो है अच्छे से उनको उनका ट्रीटमेंट कर सके. ना कि जैसे सर ने कहा कि लैक ऑफ कम्युनिकेशन होगा, हमें पेशेंट की फिजिकल एग्जामिनेशन करनी चाहिए थी स्टार्टिंग में, जो चीजें हमारी मिस आउट हुई, अगर वो टाइम के अकॉर्डिंग हो जाती तो हमें इतना आगे तक ये प्रॉब्लम क्रिएट ना होती. तो यही है कि हमारी कम्युनिकेशन अगर अच्छी होती तो हम आगे डॉक्टर को भी अच्छे से एक्सप्लेन करते, तो हमारी जो है कम्युनिकेशन स्किल में भी हमें इम्प्रूवमेंट करनी चाहिए.
Very well said. I'll just quickly summarize, because such strong points and such well expressed points, I don't want the opportunity to let go. So Priya did speak about checklists, handover checklists, but more importantly, she mentioned about transparency and honesty in fulfilling and complying to the checklist at the patient bedside. Hats off to you, girl, because this is something which we keep propagating, which we keep insisting, and probably every administrator, educator, senior sitting here will agree to it. And second, such a valid thing, and I'm surprised, taken by surprise that the way you have actually put across the concern regarding time management related to your patient ratio and the multiple tasks you handle, your expectation on the documentation quality and content in the documentation from the seniors. Very well put demand, Priya, and I appreciate you on that. And most importantly, your communication skills. And needless to say, आपने इतनी अच्छी तरीके से communicate किया है, clearly बताया है. This is the quality of communication.
दूसरा चाहिए तो वो भी मिल जाएगा.
Shobha, can you please mute yourself? Thank you. Priya, the most important was the communication, which you had mentioned. Communication is something, and as a staff nurse, what you need to do, because Friends, I would like to draw one very valid point, which probably directly or indirectly Priya mentioned and expressed to all of us, is about the trust of patient on the staff nurse, confidence level of the staff nurse in front of the patient. So it's two-edged, and I think this, as seniors and as mentors, as caretakers for them, we are responsible to ensure that their confidence level is sustained in front of the clinicians, patients, and family. We are responsible, and we have to do every bit that the patient's trust on the nurses is sustained forever till the time in their journey of treatment and hospitalization. But with this, my gratitude, while it goes to Priya, I move to Sunita. Sunita, through this, a quick last 2 minutes on what any message you would like to give to the entire panel and not the entire audience here, and through the recording to the fraternity, healthcare fraternity, on how to prevent the misses when we talk about the basics in patient care and patient safety.
Yes, ma'am. To summarize, whatever we discuss include everything that we discuss to prevent this misses from occurring. The first, we have to learn the basics. So we should never forget the basics. So as a nurse, the basic means whenever you enter the department, that is where you get the allocation of the patient. So your work starts from getting the patient allocated to you. Once you get the patient allocated, the process begins. Again, my topic, the process. First, how you attend the patient, that is the assessment, nursing assessment. So every step is in the process. Once you follow the process, you don't skip any point. So the chances definitely gets out of that, because once you are being hurdled in the step or check or the checklist, you definitely don't commit mistake. But again, committing mistake, error is to happen. That is something else. But we can definitely prevent it from occurring and happening.
Very true. Absolutely. And moving from Sunita to Ashwini. Ashwini, your 2 pence. You're muted, Ashwini. Yeah.
Yes,
sorry.
yes, ma'am. Ma'am, most important thing, already Dr. Ashutosh sir had spoken about the asking the patient being more empathetic. And I will insist upon a good quality handover from the nurses, which only helpful for the correct and accurate document. And my dear, all the nurses who are being part here, accuracy, transparency, timeliness, and the completeness of the handover, which, and based on that, it's a professional handover is something which is mantra of continuity of patient care without having any gaps. Might be we will feel that is smaller gaps which will impact on the patient care a lot. So I wanted to insist on the senior people to be focused to ensure that and teach in a proper way to get the proper fulfill completeness of the document along with the patient physical examination.
Very nice. Very well said, Ashwini. Thank you so much. I think handovers is something is a part patient assessment as well as documentation. So you actually addressed your the SAR points and the points which you are working, and it's quite evident in your workflows and your success. Thank you so much for expressing. And last but not the least, moving the baton to Dr. Ashutosh. So what would be your pearls of wisdom from this platform to everybody before we part to take home? Dr. Ashutosh?
My 2 bits to the junior nurse. Number 1, talk to the patient. Yeah, okay. Can you hear me?
Yes.
Hello. Hello. Yeah.
You're audible.
My 2 bits. Number 1 thing I want my sisters to do is, before anything else happens, go to the patient, hold their hand and just ask them, how are you feeling today? Only this thing. Number 1, it immediately makes the patient feels good. It makes the patient's relatives have faith in you. And number 3, it gives you a very quick snapshot of how the patient is feeling. Either the patient is all right or the patient is not all right. If the patient is not all right, then we can continue to look for the reason. That is one. So 1 line, how are you feeling today? Okay. Next thing is, I personally feel whatever errors generally happens because from the bedside nurses is primarily because of lack of awareness. We have talked about this. My idea is, sisters, please increase your awareness, ask questions. Please be always question, if you don't know something, ask your seniors, the consultant or the doctors, whoever is available. Nobody will ever refuse. And I will give you a very nice trade secret on this. If there is one person you want to ask a question to, ask it from the RMO. RMOs are young, they have got enough time in hands, and they are mighty flattered when pretty young things ask them questions. And believe me, and RMOs are so flattered, they would love to show their little knowledge off to you. And they will, in fact, explain the entire goddamn Davidson to you if you just ask them questions. Ask questions to whoever who can teach you. Okay, that's about mine.
Thank you. Thank you, sir. Thank you very much. And with this, while we come to the end of this panel discussion, and to sum up, friends, I would like to draw your, and I've taken some stats from the WHO website, recently published, as recent as 1st of September 2023. And it very clearly mentions that 1 in every 10 patients is harmed in healthcare. And of course, there are nearly 3 million deaths occur annually due to unsafe care. When we talk of unsafe, these missing bits in the journey of care, in the cycle of treatment, makes it unsafe. And that's the reason the buzzword patient safety becomes more and more attractive, becomes more demanding. And friends, more importantly, in low to middle income countries, it is as many as 400 people die because of unsafe care. So with this, more and another interesting fact is if we plug these bits in a single patient, it actually adds a lot towards economy. It's almost 15% up in the financial gains if we plug these gaps. Just one line on this, I'll draw your attention to the 6th slide, which I showed, that and when I said the stay in the high dependency unit increased by 2 days before the patient was stepped down to the ward, right? There could be plenty of them, but the studies say that there's almost a 15% gain, financial gain, when we plug these, per patient, when we plug these missing bits in the journey of care. With this, we close this panel discussion, and I'll stop here and wait for any questions, and as well as comments from I would say one of my gurus, and Ma'am Thangam, for your remarks.
Thank you so much. Thank you so much, Sandhya, Dr. Ashutosh, Ashwini, Sunita, and definitely delighted to meet Priya for sure. So while you all were discussing fantastic points, I was also writing few things on the side just to say what value can I add. So I always like to share stories, right? So when Dr. Ashutosh was lastly mentioning the best person to ask question is RMO, that I 200% agree with you. When I was a young nurse, I was actually known as Y baby. The doctors had named me as Y baby because for everything, I will go and ask them, why did you do this? Why did you order this? Why did you do like this? So they, whenever they will see me, they'll say, oh my God, again, she's on duty. But they were happy to be around. As Dr. Ashutosh mentioned, they don't like to say that I don't know. So they will read up and they'll come. So I'm sharing this story for all the young ones. Please don't think that, learning can only happen if I read a book or if I go to the Google. They all are available. When we were young, we did not have Google. So we were actually reading textbooks. So that is a tip, because the more you have knowledge, then the challenge is to transfer the knowledge to your workplace. So that's why the why part is very important, because that is something we teach in the leadership also, is that most of us, we tell everyone what to do. And many of us, we will tell that how to do, but we seldom try to explain why to do it.
Right.
And probably that is why we are still lacking in all those A's. I was delighted to hear awareness, alertness, attentiveness. And I asked one more A there, keep asking, ask, ask, ask. And for all this, one more A is very important. The only word, when you add the numbers, it goes to 100% in the entire English words. That is called attitude. You can have everything in the world. You can have the entire knowledge. You can have all the degree. You can have all the experience. But do you have the attitude to hold that patient's hand? To ask this patient, how are you? Or when the patient says to remember my theory of nursing process, collect data, analyze, assess the patient. So just to ask the patient, that also takes me back to my guru, who is my intensivist guru, Dr. Vijay Kumar, who taught me almost everything in critical care. And I also remember a pediatric surgeon I worked with, Dr. Hariharan. They both were in Saudi. So during the rounds, the first questions they will ask, not just after the patient, how are they? Before anyone starts answering anything, the pediatric surgeon will say, Susu potty, hua ki nahi, bacha. Exactly the same word in Arabic, he will ask, has the patient done susu and potty? Then we all will be laughing. Then he said, it's nothing to laugh. That is the most basic need for a human being is elimination. Have we got that out of the way? Then comes, patient is eating or not eating. And then Dr. Vijay also in our critical care where patients are on IABP and this and everything, he will always be asking about elimination, nutrition. That means hydration, nutrition, elimination. Basic, Maslow's hierarchy, basic. So we know all these things. I'm sure that everybody sitting here knows this. Do we have the heart to actually practice? Remember that I have to test the patient. I have to ask, have they, passed the motions? Because that's very important. So that's my bit from my side. And now for educators who are all here, I will give one, methodology, that even academicians can take it. In hospitals, there is a simulation-based learning called roving patient. So there is a paper written on that also. Roving patient means, let's say in Vasant Kunj or Medanta or Gangaram, this happened. So what you do is very quickly you create a small drama about the patient, it's like a simulation, write the background, go to the ward during shift handover, get all the nurses into an empty room, play this drama out. Patient is, post TKR, this is what happened, patient this complaint, and exactly the same thing. And they are observing this like a drama. And then immediately after that, do the debriefing, do not teach them. Ask them what went right, what went wrong. They themselves, when they watch something happening, they will know, oh, this was the gap. And for them, it's a very powerful learning. And they will remember that for a very, very long time rather than, giving them lectures, understanding what are the reasons for constipation, what happened, and how does this impaction with overflow happen. That's all gyan. It can very easily happen. You can do that part also towards the end of the debriefing. It is possible. And in that paper, it is written, they almost covered, if the numbers are correct, if I remember, 250 nurses in 1 week. Same patient traveled across all the units and all nurses were gone through that. Because when we think simulation, we think I need a lab, I need a mannequin, I need many things. No, it's just the education department. One patient acts as patient, assign nurse, TL, do the drama, let everyone, opine on that. And what we are doing in this format is also a simulation-based learning. See, all that you discussed were nothing related to a chart where you wrote, well, TKR, what happens, what are the complications. This is more about using our decision-making, problem-solving, critical skills, which we already learned. So same thing, the academicians also need to use that, allow people to experience, allow people to discuss, to say this is what it is. So that is the one thing I just wanted to remind is, remember roving patient. You can design learning within the hospital in between the, shift handover, maybe in the afternoon, maybe morning. I mean, you can decide how you want to do to the relevant audience. And congratulations to the entire team. Fantastic discussion, lots of points added. And very rightly said, WHO is very worried about the patient harm that is being done. And WHO really wants us to up our game. and all that can be done also is written. One more data that I would like to share is that Sentinel events, when they studied, analyzed it, the top 3 reasons. 10-15 years ago, communication used to be right on top. Now communication became third. First point is human factors. Second point is to all of us, leadership. I think you did discuss about this. The process and the responsibility that lies with us. So I used to tell my educators that please don't tell me how many hours of training you have done. If I see that on the nurses, I know that you have done a good job. But don't tell me I had been teaching and training for hours. And similarly to the academicians, I would always say that your acid test is when they appear for interview, how they are doing. I really hope that you will connect your actions to the outcome, not on how much you did. It is on the effect that you have created. I would definitely love all of you to just reflect on this. I'm sure there are a lot of senior people, academicians here, and to young nurses like Priya, do not be afraid. Speak up. And when you think that you are having unsafe staffing, have the courage to speak up, to say that I am under pressure because I have unsafe staffing. Don't wait when something happens, then you say, I'm so sorry, madam, I had 8 patients. That is not very professional. Talk about it before. Call and say, I'm sorry, I have 8 patients. I think it's very unsafe for my patients. And I'm very sure the supervisor and the nursing head is definitely going to listen. So the pressure comes from both sides. Both sides, the leaders and the caregivers, the frontline caregivers are asserting each other to make the environment safer for our patients. And we are in this game for them. Nobody comes with the intention of harming patient, but harm happens because all those 3 things that Dr. Ashutosh mentioned. You're not aware of what is happening. You're not alert to what is happening to the patient. And you're not attentive to what the patient is saying or the patient is just expressing on the face. A patient who is looking very uncomfortable, will you ask the patient, I'm so sorry, you look little disturbed. Can I help you? Is there something bothering you? Because pain is expressed different ways with different patients. So I can actually talk for another 1 hour, but I would say thank you so much, Captain Sandhya, Dr. Ashutosh, Sunita, Ashwini, and Priya. Very, very delighted to see the entire panel, and you have given so many pearls of wisdom. And my request to everyone is, make one decision today that I will do something different because you came here today. If you do one positive change in your life, then I think all this effort that all of us have done is, there is a faida. Otherwise, it is yet another webinar. So yet another webinar, yet another conference does not make us better nurses. So let's commit to something different today. So with that note, once again, thank you so much to the Delhi chapter. A fantastic job. And in December, please watch out for our, announcement. The Empower Hour will be converted into a quiz. So we just have to, work out the logistics and we will see how best we can do that. Thank you once again and take care. And Priya, please come on the video so that I can say bye to you also. Very well done, Priya. I'm very happy that, in every Empower Hour, one young nurse will come and say, there is still left in nursing. Not everything is lost. So you are a champion for tomorrow's nurses, and we are all going to support each one of you. So join us for more Empower Hours. We'll continue to do that in 2024 also. Thank you once again and take care and bye-bye.
Bye, ma'am.
Thank you, ma'am. Thank you, everybody. Please have a great day ahead. And we close this session formally. Thank you. Bye-bye.